Welcome to Chemopalms Recovery's YouTube channel, where we post continuing education videos to keep you up to date on relevant information in our field. For more information on our CEUs or to be put on our mailing list, email ceu@chemopalms.com. This presentation is on HIV and people who inject drugs. Thank you to our presenting partner, Lisa Hinson at Landrum Counseling and Consulting. Don't forget to hit the subscribe button to stay up to date on more continuing education videos just like this one. Hope you enjoy.
And then I'm going to pass it off to my good friend here, Lisa. I think Lisa and I have known each other for probably 5 years now, something like that. It's been a while now. So this is the second time she's presented. She's an awesome presenter. So I asked her to come back and do a very needed topic. So I'm pretty excited. So I'm going to hand it off to you, Miss Lisa.
Thank you, Miss Crystal. I appreciate that. And yes, we have known each other for quite a bit of time, old teammates and new teammates. So, and I love what Chemopalms does. I've referred clients there, and I've always had a good outcome with y'all. So thank you. My name is Lisa Hinson. As Crystal said, I am a LCDC in private practice out of Austin. I work in a collaborative practice with 2 other therapists. We do EMDR. We do everything from EMDR, trauma, substance use disorder, families, interventions. So check us out. And I appreciate you all being here to hear me present today. I'm actually going to talk about specific HIV. This might be a little bit of a different take. I'm going to do HIV and IV drug users because there has been an uptick actually since COVID started. So I'm going to give you some. Information, and we'll go through. I'll stop about 11:45, and I'd ask that if you have questions, hold them then, and then we'll take them at the end, and then that way, because I've got a little bit of information to cover. So I'm going to do a share screen. Let's see. Alrighty. Okay. So here we go. My contact information, if you'd like to reach out to me, will be in the slides that get sent out. So quick little bits of information. I am receiving no sort of financial compensation for this. So there's no compensation from anybody, company or otherwise. And I am also telling that everything in this is in the public domain. I don't have sources cited at the end, usually on this type of presentation, but I will go ahead and add those before I send them off to Crystal so that she can make sure that everything is in there. And if you want to reference it, you're more than welcome to. Okay, so let's get started. Prevention and treatment strategies. I've got some data in here, and then hold on, give me a second. There we go. So COVID and IV drug use risks. Since COVID has started, there's actually been multiple articles that have referenced higher IV drug use along the spectrum. And part of that is due to one, isolation, and higher levels of relapse that have definitely happened since COVID. If you're in the field, you've probably seen that within whatever capacity that you work in. I know that I've seen it in private practice, and I've also seen it just in terms of an much higher incidence of referrals for residential treatment and detox from families and families who are concerned about a family member who's using IV drugs, and then also individuals who are IV drug users seeking treatment. So probably more than I've gotten within about the last 4 or 5 years. And I can tell you that was a red flag for me, which is one of the reasons I wanted to focus on IV drug use. So a higher prevalence of exposure and infection is multifactorial. Unsanitary environments and poor hygiene. That goes along on average with the environment that an IV drug user may go to use, or they may be living in. And definitely lack of access to services that normally might be open for people seeking treatment might not be open during this time. They may be shuttered. They don't have access to maybe medical personnel like they would prior, or even to resources for MAT, which I'll talk about in a little bit. So decreased access to services, challenge with social distancing and quarantine. Not all IV users use alone, especially if they're using in community, in a rundown location in which they go to get their drugs and then also use in the same place. Or if they are experiencing any type of disconnect from family or homelessness, they're definitely going to be in a place that is unsanitary and where there's poor hygiene with lack of access, just the most basic things that we need, whether that be housing, shelter, food, facilities, hygiene facilities. All of those things are not necessarily available, actually, more often than not necessarily available to IV drug users when they're using in community or with each other when they've reached a certain point in their use. Another thing is incarceration. But I can tell you during COVID, there have been, when I pulled some statistics, there have been less arrests for IV drug or drug charges or drug using during COVID because people are focused on incarceration and health of already people in the criminal justice system. So comorbidities have had a higher rate, HIV, hepatitis, TB. There was also something that has just come out with during COVID, which is a medical report for higher risks for infectious endocarditis for IV drug users. This is not something that's been looked at before as in depth is medical complications related to the heart with IV drug users. It's mostly focused on liver disease, TB, hepatitis, HIV, that sort of thing. Infectious endocarditis is when there is a buildup of liver around the lining of the valves and it stops heart flow. And so during COVID, what hospital emergency rooms are reporting around comorbidity with IV drug users is an increase in them seeking emergency services for this type of endocarditis, which is directly related to their use. So most common IV drugs that are used, heroin, methamphetamine, cocaine, and ketamine. Southern and Western regions have higher use of stimulants. Midwest and Northeast regions of the United States use primarily heroin and other opioids. That's on a national level. In Texas, the most commonly injected drugs are number 1, heroin, 2, speedballs, which is heroin and cocaine, and then 3rd, cocaine on its own. So IV drug use and exposure for risk with HIV and Hep C and other STIs, needles and syringes, and that's typically because IV drug users share their syringes. Even when the only time that risk is reduced for IV drug users is if they are using a rig that is not a detachable needle. Detachable needles, even though IV drug users may think that they are better, at least there's some protection because they're changing out the needle, there is still blood that can be caught in the tip of the casing that gets re-injected. So that's the problem with using needles, casings that have a syringe that has a detachable needle. Really, the least at risk in terms of sharing a needle is actually just getting a whole new needle, which can be a challenge. And we're going to talk about that because there's actually some resources in the state of Texas that allow people to do pick up fresh needles without having to do an exchange. Prep equipment, cookers, cottons, water ties, even alcohol swabs can become contaminated during prep process. Fingers and hands, because if there's an open cut or wound, can become infected, spread hepatitis. It can also spread HIV. And then surfaces, when blood from an infected person contaminates the surface and is reused by another to prepare injection equipment. Most times, folks, when they're using IV, don't pay attention. They just don't pay attention to it. Don't always stop to clean up their prep surface. They may only use a detachable needle in the same syringe, and that's about as far as they might go. They don't, it's not necessarily going to be, I'm going to wipe my hands down, or it just doesn't always look like that. Some people do. In other parts of the country where there are actually vibrant SEP programs, which is syringe exchange programs, or SSPs, sterile syringe programs. People can actually go to a vending machine and get absolute fresh needles. They can also get different types of riggings. They can go and actually bring their own drugs to a safe room to use, which is clean. And it also offers them the opportunity to get information about resources if they want to get into sobriety, or if they want to go ahead and learn safer sex practices or safer using practices. Those do not exist in Texas. That type of community use room does not exist in Texas. But Texas does have some SEP programs in most of the major cities, but they are not specific. They don't only focus on needle exchange. HIV and the linkage between IV drug use. Every 1 in 10 new cases of IV drug use and exposure to the HIV virus is contributed with men who have sex with men, is unprotected sex and injection drug use. It's either going to be this statistic is the same for both of these groups. 1 in 10 new cases of HIV exposure is attributed to injection drug use across the spectrum, but specific to men who have sex with men, male to male unprotected sexual contact and IV drug use is in that group the highest. HIV can survive into the syringe for up to 42 days, depending upon the temperature and other factors. And that's a long time, because for IV drug users who are who don't have resources to either acquire new needles or buy new needles, or even do a detachable needle change within the syringe, they can viably use the same syringe and the same rigging for up to 30, 45 days. That is not uncommon. There is a 1 in 160 chance of transmitting HIV every time a person injects drugs. That may seem low when you think about some of the other substance use statistics we have, but for contracting HIV, it is not. Sharing needles is the second riskiest way for IV drug users to contract or be exposed to HIV. The first is unprotected anal sex. HIV and Hep C can be transmitted the same ways through needle sharing and works. So PWID, if you're not familiar with that term, PWID is persons who inject drugs, and HIV in the community. So within, I've got some data that I'll show you after we go through these. IV drug use is the second leading cause of HIV infection for African American women. I did not, I knew it was a high statistic, but I did not realize that it was the second leading cause of HIV for African American women. And then looking at all the other factors within that community, you can begin to see why that might be. What are some of the contributing factors that give that statistic? The third leading cause for African American men. So men who are in the African American community, in the Black community, who are IV drug users, contracted HIV is the third leading cause, and then for HIV infection for women, it's the second leading cause. And so approximately 1 in 10 or 10% of the HIV diagnosis among Hispanic and Latino is attributed to IV drug use. And that breaks down to 3% of cases among men who have sex with men and intravenous drug use. White female IV drug users have the highest rate of HIV at 50% across the board. white males have the second highest. Then it is African American females, African American males, and then Hispanic and Latino. The white female IV drug user having the highest rate across all communities. That community has seen the highest increase in HIV cases related to IV drug use in the United States within the last 3 years. I can tell you, finding statistics specific to IV drug use and HIV for communities has been difficult. There's not, HIV is still stigmatized across the spectrum, especially when it comes to IV drug users. People are reluctant to talk about HIV and STIs because of this, around sexual risk. They're reluctant to discuss that, but they are really reluctant to discuss people who inject drugs along with HIV because of the stigma that is still attached to IV drug use. And people have all sorts of ideas about that. But when you're looking at contracting or being exposed to viral epidemics like HIV, COVID, other viral infections and bacterial infections, this is a part of the substance use spectrum that doesn't always get treated the same way as somebody seeking treatment for alcohol or seeking treatment for, prescription pill disorder or other illegal substance use or legal substance use. So, alcohol, but marijuana, this idea of somebody getting treated for IV drug use is not always seen the same way as somebody else who doesn't have the stigma of that because of the idea of what that means, or the judgment that somebody may have about what type of person is injecting drugs. So that is a lot of what I think people who are trying to seek help for IV drug use contend with, especially in especially in minority communities, because again of this idea that this is what an IV drug user looks like, and these are the ways that they got exposed, which has much more stigma attached, especially when you look at some of the ways that people can support their IV drug use. So here's one of them. This is across the United States. Syringe sharing among people who inject drugs in 23 U.S. cities, and I'll give you the breakdown of the cities when I send out the slides. So if you look at least 32% of people who are using, who are injecting are sharing syringes. 48% are age 18 to 24, 44% 25 to 29, 39% 30 to 39, 30%. And you can see as people age, it gets higher as they move up generationally. But the thing is, syringe sharing is most common among younger people. I can tell you from personal experience in terms of my, working, I should say personally in my life as a professional, working with folks who are IV, who use drugs IV. Older adults that I have worked with, 40 plus, 45 plus, who may actually be seeking treatment, who have sought treatment for sobriety and recovery to get clean and sober from IV drug use and primarily opiates, who are older, do not share needles because they understand the threat of HIV infection or of hepatitis or other related TB. So they don't share needles. And they've also, because they're older, have more access to a clean needle through Medicaid, Medicare, or other medical conditions that they may have that give them easier access to medical services so that they can get clean syringes in one way or another. But it's mostly younger people. So IV drug use and viral infections. More and more people who become diagnosed with HIV through through IV drug use also tend to have a co-occurring with Hep A, B, C, or D. There's also an increase in hepatitis superinfection, which is hepatitis C and D together, which makes it much more, hepatitis B and D, which makes it much more difficult to treat the hepatitis. But also when you have HIV as a co-occurring, many of the treatments can interfere with the way HIV gets treated, along with treating somebody who is an IV drug user who wants to get sober and not use anymore. So that is definitely an increase that we're seeing in terms of hepatitis superinfection, along with HIV, along with IV drug use. So looking at the way to treat that is multi-pronged. So co-occurring is HIV and hepatitis, no HIV, hepatitis T and tuberculosis, HIV and TB, HIV and STIs, Hep, TB, and HIV. It is not uncommon when somebody is seeking services for treatment that is a person who has IV drug use to see a combination or all of these things. It's not unusual, especially depending upon behaviorally and environmentally what their approach has been and to getting high, and what they have been doing in order to economically support themselves, either through basic needs and also in exchange for works, needles, drugs, whatever that might be for them. So typically people who are HIV positive are at a higher rate for syphilis, gonorrhea, and herpes than people who are not HIV positive. Not that they're not high risk infections to begin with in terms of STIs, but it's just people who have HIV are much more susceptible. And then, if they've had it, they are much more likely to get HIV in the future. That is directly related to the behavior that caused exposure to STIs to begin with. So, and if there's not an intervention in the way that person is having in the way that person looks at sexual activity, or even their partners engaging in sexual activity outside of the relationship, or all of the different ways, if there's no relational change in behavior, then typically the same activities that expose them are the same activities that they will continue in, which increases their risk for HIV. And it might be that there is one partner who is an IV drug user and one who is not. And so that can also create the risk of reinfection and initial exposure. Infection is less likely if somebody is on ART. Infection being exposed to co-infection. So if somebody is taking antiretroviral therapy and they're HIV positive, they are less likely to get syphilis, STIs, syphilis, gonorrhea, and herpes if they're on ART, even if they're HIV positive. There's a less likelihood of, even if through exposure, that they will go on to develop any sort of infection. And so what we talk about, choose less risky sex activities, use a new condom for every act. Even amongst younger people, there's this idea that if there seems, and when I say there seems to be, I can certainly look at statistics that can bear this out. Also in my professional experience and talking with other colleagues who work with young adults and adolescents, this idea of, if I have one condom, then that's all I need, is I just need to have one condom. And I'm good throughout the entire sexual experience I'm having, which is actually incorrect. A condom needs to be used for every new act within the scope of the experience that somebody is having within the sexual situation. So, oral sex, one condom used, thrown away, move on to the next act, intercourse, new condom, thrown away. And that's just because of breakage. and not being able to contain bodily fluids. So there's a risk of overflow. I mean, to be basically honest. So the idea that if I'm using one condom for multiple acts, I'm safe, that's not accurate. There's still a very high risk of exposure to STIs and HIV through that process. Risk is also reduced for HIV and co-infections if a partner is using PrEP. I'll go back to the example. Somebody is an IV drug user and they are at a high risk. They get exposed. They have HIV. They do not go on ART immediately, but they get so the other partner can be exposed. For long-term use is what PrEP is. PEP is what they would use during the first 72 hours of initial exposure. I'm sorry, I went too fast. So here is the latest for IV drug users who have been exposed or diagnosed with HIV. This is definitely for those IV drug users who have new HIV diagnoses by sex, race, and ethnicity in the transmission. So as you can see, if you look at red is for white, the gold is for Black African American, and the blue is for Hispanic Latino. Across the board, except in gay and bisexual men who inject drugs, the Hispanic and Latino has a higher than the Black and African American community. The white community across the board has much higher in every category. Men who inject drugs, this is not bisexual and gay men. These are men who identify as heterosexual. So you can see that all of that just goes to show you that this is definitely an increase in what it has been over the last time the study was done was it went through up to 2016, has increased since then. HIV treatment options for people who are injecting drugs. So this is really what it looks like when somebody has been exposed to HIV, thinks they may have contracted it, and initially generational testing. So they take a 4th generation HIV test. When they go into a lab, this is what they're going to get, hopefully, because not every lab does this, not every agency does this, and they'll get STI testing. So if they are negative, then one of the things that they will begin, the first thing that they look at is their HIV status. If they are negative, one of the things that they'll be discussed is assessed for PrEP or PEP, because if even if they're negative, it might be depending upon the way they were exposed. PEP could be appropriate. If PEP is not appropriate, then definitely PrEP, which is pre-exposure, and that is an ongoing medical intervention that people can use if they engage in behaviors that have a very high likelihood of exposure, whether it's IV drug use, whether it is risky sexual behavior, or a combination of both. For people who inject drugs, it's usually a combination of both: risky sexual behavior and the fact that they're using drugs intravenously. The other thing, so that then they will go and look at risk of STIs, PrEP or PEP, adherence interventions. What are some ways that you can decrease your risk? Does that mean you stop using? Does that mean you go to treatment? Does that mean you need economical support, behavioral intervention, social services? What do you need in order to support moving into less risky behavior? And then if they decline PrEP, because not everybody decides they want to go on PrEP, even the partner of somebody who is with an IV drug user, even though they may not use IV drugs and it would benefit them to go on PrEP, they may choose not to. They may say, you know what, I don't want to go on PrEP. And some folks, even if their partner is HIV positive, just don't want to do PrEP. They refuse to. They are willing to practice safe sex, but they're not willing to take the medication that PrEP is required. So if somebody, again, is negative, if they are refusing any sort of risk reduction that has been offered to them, it is suggested that they retest every 3 to 6 months. And at the time of retesting, continue to assess and invite any sort of behavioral health or social services that they can take advantage of. So for somebody who tests positive, the acute infection is the immediate care needs to be definitely getting them to link to long-term care, assessing for initiation of when antiretroviral can start, services for their partner. Services for their partner at this stage may be PEP, which is post-exposure prophylaxis, which is the medical regimen they would take after they've been exposed and within the first 72 hours. And they usually that is taken for up to 30 days. Again, behavioral health and social services are offered, and hopefully when that intervention happens, that they will be willing to take advantage of that. And then for established ongoing HIV infection, again, maintaining the link to care with their doctor and maintaining ART. Partner services, again, could include after PEP has been completed, starting PrEP, because if this person is has an established HIV infection, until their viral load is low enough or undetectable for a partner to decide to discontinue PrEP, most healthcare providers are going to suggest that the partner continue PrEP until such time that either viral load is undetectable or they choose not to do it anymore, or there's been a behavioral change. So here are the statistics in Texas that I could find. It was a little bit difficult. I had to use the TEDS research, and so it's a little bit dated in terms of it's not necessarily within the last 24 months. It would be 3 years plus. So for people seeking treatment, people who inject drugs and are HIV positive seeking treatment, 33% of all patients that were admitted to treatment facilities that received public funds were IV drug users. The National Early Warning System reports that 85% of heroin users, 31% of methamphetamine, and 2% of cocaine were primarily IV users. That was their preferred method of administration. It wasn't snorting. It was direct IV. And again, you can see, you begin to see the connection to opiate use. And especially there's been an increase in IV methamphetamine use since during COVID. So that was 2018. For people who inject drugs and have a positive hepatitis, 50 to 90% are co-infected with HIV and have IV drug use. So 50% to 90% of IV drug users who have HIV continue to inject and also have co-occurring hepatitis, or some, whether it's Hep C. The problem that somebody runs into with having a co-occurring infection of Hep C and HIV, depending upon what stage they are in, meaning if it is established or it's early, can also have an impact on the way that hepatitis C is treated. Typically, hepatitis C is treated now. It's a series of shots every day over a period of time that, again, similarly, undetectable viral load for hepatitis C. The hepatitis C is not detectable, and it's considered that the person no longer has Hep C. But running that treatment concurrent with ART or can present some problems with medical contraindications and medical interactions. And then along the time, also having somebody try to get sober off IV drug use. So IV drug use is in Texas is 14% higher than the national average. One of the things that I learned in looking at the latest statistics is that Texas has higher than national average in a lot of areas across IV drug use and HIV. And in the way, not only that, but in the way that we treat it in state facilities, and sometimes even in private facilities. So as of 2017, only 35% of facilities in Texas screen for hepatitis. In a recent survey, federally qualified health centers and treatment facilities found that 61% of those facilities surveyed reported not having hepatitis testing because of capacity or lack of funding. Most of them looked at lack of funding. So, which can be scary. I mean, when an IV drug user seeks services, it's really a multi-pronged approach. They need testing across the board for STIs, HIV exposure, hepatitis, all the hepatitises, and then looking at any sort of liver dysfunction, and then now with the newer diagnosis of endocarditis, I mean, looking at that too. So, I mean, it's a full medical workup. And, when somebody seeks treatment, those medical services or labs may not be available to them. They may only really be testing for most basic STI exposure and HIV exposure, not necessarily hepatitis. So really the best way in treating somebody who is an IV drug user with HIV, and again, somebody who is HIV, somebody who's been exposed to HIV and who's not an IV drug user, that is coming directly through usually their sexual behavior. For somebody who is an IV drug user, because that is the second highest risk behind sexual behavior, those numbers are going to be much higher and can be, what's the word? They can be more of a challenge to address, because for somebody coming off IV drug use can be it's an incredibly hard detox. It's an incredibly hard way to administration route to stay away from, because it's so instantaneous, especially with opiates and amphetamines. So assess and referral for both SUD and mental health treatment, and then the most appropriate care for any HIV, Hep C, or co-occurring infection diagnosis that happens, which includes TB, because many times the environments that IV drug users might be using or living in, there is very high risk for exposure to TB. Harm reduction. So when we talk about, I'll get to that in a second. So harm reduction approaches: medication-assisted treatment, SSP, syringe service programs. There's 6 in Texas: Dallas, Houston, Waco, Austin, Fort Worth, and Abilene. There is a website that you can go on, which will give you a direct connection to those clinics, and they give a number, and they may talk about what services they offer, they may not. Usually they work under the radar. They offer services typically across the spectrum, where somebody can pick up clean syringes. In the process of, they also will get an assessment and introduction to any services that they may need. Being able to talk to somebody about how to get sober, how to get treatment, how to get testing for HIV. They can do labs there. That what they will not get is they cannot go there just to swap syringes. They cannot go there for a safe use room. We don't have those. Other states do, but Texas does not. So I talked about PEP. Exposure within 72 hours. You've got to take it for 28 days. It is not an ongoing treatment. It is usually one-time emergency use only after immediate exposure. PrEP, it doesn't always work. It does not always work. It doesn't always block the HIV vaccine. It doesn't always block HIV from entering the cell. But what it's designed to do, and most and for most folks, it blocks the virus from entering the cell. It really just kind of puts a cocoon around it. It's 1 pill daily for 30 days. And again, it's not guaranteed. It is strict adherence for the best possible outcome. And so what part of that can mean, and I'm going to stop screen sharing, what part of that can mean is that when you're looking at trying to get services for somebody for PWIDs, is that it really is looking at behavior across the spectrum to address what the trigger could be for them to continue using. One, so with women, you have a very high rate of them going into sex work to try to make money to use, or because that might be if they are being trafficked, that's the only way that they can get drugs to support their habit. I mean, so there's lots of different behaviors that can be double exposure and doubly and triply high risk, depending upon again in the community, and it also depends upon gender, what they're doing, and what if there's trafficking involved, and especially with younger adults too. So that's a lot of information, and I again will give resources at the end when Krista sends out the slides. If you have any questions, please let me know. I'm happy to answer them. What do we got?
Awesome. We do have a couple, and so I don't want people to think I was ignoring them. I was just kind of like waiting till the end. So one of them I was able to answer quickly, so I just went ahead and did that. But this person says, is there a risk with oral sex?
Sure. Oh, absolutely. Anytime that there is an exchange of bodily fluid in any way, shape, or form during sexual activity or IV drug use, there is always a risk. Condoms and condoms are safer sex. They're not a complete they're not a complete barrier because condoms break. There's always a chance that there can be some fluid leakage before the sexual act takes place. There's lots of different ways that people can be exposed. Condoms provide safer sex. So yes, there's definitely a risk with oral sex. So when young people say, well, you can't get HIV with oral sex, we're not having intercourse, that's not true.
Right.
So there, one of the Nancy, I think it was, made a comment, and I appreciate that. She said that PrEP isn't only for 30 days. It can be continually used. It can be consistently used. That is correct. And thank you, Nancy, for making that known. PrEP can be ongoing. It's not just one time. PEP is one time in an emergency situation, but PrEP can be ongoing. So a partner, somebody who's HIV positive, their partner can be taking PrEP for for multiple months, and they're under a doctor's care, and they go back and have their labs run. But yeah, that can be one of the most significant and successful ways to reduce the risk for a partner to become HIV positive with regular exposure. There's also other behavioral interventions along with PrEP. So yes, so thank you, Nancy. It can be consistently used as an HIV intervention in relationships.
Yeah. So this person said, what does NPEP or NPEP state mean? You'd mentioned it in the thing.
So PEP is pre-exposure, is post-exposure prophylaxis. And what that means is that when the individual has been exposed to HIV within the first 72 hours, if they start PEP, then what will begin to happen is that it's designed to attack the HIV virus, so that, and also protect the T cell so that somebody doesn't become positive. Did I answer that correctly?
Yeah,
Maybe I misunderstood. I didn't hear NPEP. Yes, NPEP is the same as PEP. I'm sorry, I didn't hear the NPEP part. So yeah, they are the same.
I think we're getting feedback from me on your end.
Okay.
Let me see. Okay, can you separate the statistical data into homeless versus non-homeless, and how does your approach to helping them differ? That's a loaded question.
That is. You know what? So can I separate the statistical? I can. Here's what I'd like to do so I can give you accurate information. And I may not have as much, and I don't have as much time with what we have left. If you want to, you can, if you want, go ahead and if there's a way that I could get your email, if you want to, send me a chat directly, I can get your email, and I'm more than happy to respond. For those in the dating world, if both agreed to be tested before becoming sexual, how accurate are all tests? Well, in terms of how accurate are all tests, I mean, each test is for the individual, and typically tests are accurate. If you're looking at getting pre-tested, tested for HIV before a couple engages in sexual activity, does that, and both tests are negative, are they accurate? Sure, they may be accurate in the moment. However, that doesn't always clear somebody to not be exposed to HIV if the behavior of one partner or both put them in a high-risk situation within the last 60 or 90 days. So if you're asking if somebody can be tested and have a negative test, they can, and engage in behavior in which they are exposed to HIV and become positive, yes, they can.
Right. Still that window. This person said, when living with a family member with HIV and being tested twice within a year, is there any concern after of exposure? I guess maybe they're not living with them anymore.
I don't know. It depends on if the testing, it would depend upon, was the testing done? I'm not clear on the question. Was the testing done after the exposure?
I'm thinking that person lived with the person and then was tested twice within the next year. Is there any concern after that of being exposed? That's what I think, but I'm not sure.
I'm not necessarily understanding the question. I apologize, because it sounds like if you're living with somebody who was HIV positive and there was possible exposure and the person was tested multiple times after exposure and it was negative, depending upon how the exposure happened and what their medical provider suggested. I mean, they may have been a candidate for PrEP. For PEP, I don't know. But if they tested negative twice, then the test is negative.
So here's another one. If a person is tested positive for Hep C, but no longer is no longer testing as an active in the test results, do they still have to take precautions when engaging in sex?
That's a personal choice, depending upon what other behaviors may be present in the relationship. So typically when after somebody has gone through the newest medication regimens for Hep C, they no longer are Hep C positive.
Correct.
So could they have unprotected sex? Sure. Yet there could also be extenuating circumstances in that relationship and different behaviors that still create high risk exposure other than Hep C.
Right.
So I hope that answers the question.
Yeah, I think that I had a friend that had hepatitis C, was treated for it, had a baby, and there was no risk for transfer to the baby because there was no viral load. And so I think, with hepatitis, it's different because once you're treated, it's not they don't give you a cure, but it's really not, it's not transmittable really, but there's still other risks, like you said, so.
Okay, so Patricia, I see your comment that you've been in the arena since the 80s and not much has changed except medication. I agree. There definitely across the spectrum in all communities needs to be much more discussion about education related to high risk behaviors, behavior modification, where we can begin to talk about actually, people do have sex. And so what can we do if they're going to have sex and they use drugs when they have sex? So what can we do in order to make that a safer experience for them? Instead of saying, well, they're not going to do it, and then we just need to shut it down. That's really part of a harm reduction approach. That's prevention. And harm reduction can be part of prevention. from the perspective that what ways can we look at actually, if you're going to do this behavior is safer than that behavior to prevent you from becoming exposed. So there's lots of different ways we can approach it. And you're right, we don't talk about some of that because many people think if we talk about it from that perspective, we're condoning it. And it's not that it's not a matter of condemning or condoning. It's really just a matter of helping people be safer. And again, continuing to talk to them about the benefits of behavioral change and sobriety. And being able to maintain that, especially if they're HIV positive. So thank you all very much. Again, I appreciate everybody's input. If there's anything that you have that you want to share with me, my contact information is on the slide. Please, I certainly by no stretch of the imagination know everything. And there seems to be many of you who've been working in the field a long time too. So I'd love your feedback. So thank you. You all have a great weekend.
Thank you, Lisa. And
Thank you for tuning in, and don't forget to hit that subscribe button. See you again soon.